Yes.
All right, okay. Bismillahirrahmanirrahim. Assalamualaikum. Good afternoon. So this afternoon we will talk a bit about hearing loss, the different types of hearing loss, how they look like on audiogram, and also what do we anticipate on audiological assessment. Okay. So inshallah, I hope by the end of the blog, you guys will be able to come to our clinic and we will teach you hands-on how to hold the otoscope and also how to perform a tuning fork test. Okay, inshallah. So this is the, I'm sure you might have you might have seen this, okay, maybe in the previous lectures. The anatomy of the ear, there's the outer ear, there's the middle ear, and also the inner ear. Okay, so any pathology involving any parts of this ear will cause different degrees of hearing loss, different types of hearing loss. Okay. When we talk about the physiology of hearing, so the pinna is shaped in such a way that it is like a funnel shape. So it will collect the sound from the environment. Okay, more so on the sounds coming from anterior part, because like that's how our ear, our pinna is shaped like. Okay, so we will listen more, we will be able to receive more sound which comes from in front rather than from behind. Okay, so this sound will travel through the external ear canal. Okay, it will funnel through the external ear canal and it will hit the tympanic membrane. So as the tympanic membrane moves, it will move the ossicles in the middle ear, and eventually the movement of the ossicles it will cause movement of the fluid in the cochlea. Okay, so the movement of fluid in the cochlea will eventually transmitted into the brain by the nerves as electrical energy. Okay, from mechanical energy in the middle ear into electrical energy into the brain. Okay, so I think you can read this, like how the anatomy of the ear and how eventually the sound from the external environment perceived as sound by the brain. Okay. Okay, this is what I said. When the movement, the mechanical movement of the ossicles in the middle ear will eventually be transmitted to the cochlea, causing movement of the fluid in the cochlea, and the shearing effect of the basilar membrane will cause electrical energy to be changed. Okay, the impulse will be changed, and then this will be perceived as sound by the brain. So when you talk about hearing loss, you have to grade the severity of the hearing loss. You will see Pyoton audiogram in clinic, or even like when you see textbook. Okay, they have different levels. Okay, so I think this is universally accepted degrees of hearing loss. So if the hearing loss is at 20 to 40, we call this mild. Okay, if it's 40 to 70, you call it moderate. More than 70, it will be severe, and then above 90 is like profound hearing loss. So if someone tell you that, this patient have like a severe hearing loss, so you can gauge that the hearing loss is about 70 to 90 decibel. So this is just another diagram showing that the environmental sound and how it correlates to degrees of hearing loss, degrees of hearing levels. Okay. So another thing that you need to be able to if somebody talk to you about the Pyoton audiogram, apart from the severity of the hearing loss, you also have to be able to tell them about the configuration of the pattern of the Pyoton audiogram. Okay, is it downsloping? Is there any like a cookie pipe audiogram, or like or is it flat? Okay, because like different type of configuration of pattern will be able to tell you the different types of pathology that might correlate with it. Say like the sloping audiogram, the downsloping. This is commonly seen in presbycusis, as I said, hearing loss in elderly. Okay, we also see presbycusis causing flat audiogram. It's different type of presbycusis. you see a reverse slope audiogram, so whereby the low frequency is affected more. You see this in Menial disease. Okay. So apart from severity, you have to also be able to figure out what is the type of pattern of configuration of your audiogram. So moving on to the type of hearing loss, the first type, which is like commonly seen in primary setting, okay, is conductive hearing loss. So what does it mean by conductive hearing loss? Conductive hearing loss is when there's any obstruction or any infection or pathology, okay, in general, causing inability of the sound to travel in the external ear canal and also the middle ear. Okay, so if someone showed you a Puton audiogram which is suggestive of conductive hearing loss, the first thing you have to think about in your head is the patient might have a pathology in the external ear canal or the middle ear. Okay, so when you perform a tuning fork test, you will anticipate to see that the RNAs is negative. Okay, whereby the bone conduction is better than air conduction, and you perform Weber's test of the tuning fork, you'll be lateralized to the affected ear. So if you see, if you perform this tuning fork test and it presented as this way, so this is suggestive of conductive hearing loss. Okay. So yeah, so tuning fork test is a very good test. With although you can do it bedside without photoaudiogram, you can actually gauge the difference in hearing loss between the right and left ear, the good and the bad ear, and also the different level of hearing loss. Okay. So there's a lot of possible causes of conductive hearing loss, because it can be because of the absence of pinna, external ear canal, or the middle ear. So it can be congenital. So maybe the child or the patient is born with a malformed outer ear, the pinna, the external ear canal, or obstacles in the middle ear, or there's presence of a mass like congenital cholestoma in the middle ear. Okay, so the sound cannot travel effectively from the environment into the cochlea. So it can also be acquired. The most common one we see in primary setting is impacted earwax. Okay, it can also be because of infection. There's like furuncolosis or like acne within the external ear canal, causing significant obstruction of the ear canal. So the sound cannot travel effectively, or otomycosis, fungal infection of the ear canal. In pediatric, we also see a presence of foreign body, okay, in the external ear canal, causing obstruction. It can also be a presence of benign mass of the external ear canal. So another thing, like we usually test you in examination in your exams, would be the middle ear type of conductive hearing loss. Okay, it either be like middle ear effusion, acute dysmedia, okay, or even deep perforation can cause conductive hearing loss. So how do we treat conductive hearing loss? Since we know there's quite a list of possible causes, so we have to figure out first what are the possible causes, and we have to treat the underlying cause. So usually it can be treated medically. Say it is impacted earwax, so we just remove it in office. So if there's an infection, there's a lot of discharge, we clean the ear, we toilet the ear. And most of the time, patient can be treated as outpatient. We give oral or topical antibiotics or topical antifungal for fungal infection, otomycosis. Sometimes, when the say middle ear effusion is persistent despite optimum treatment, we might need to subject the patient for laryngotomy and grommet insertion to allow better ventilation between the external ear and also the nasopharynx. And then another type of surgery that we can perform for conductive hearing loss is stabilotomy in autosclerosis. You can read about this. Mastectomy in cholestoma, or in tympanic membrane perforation, we can also perform laryngoplasty. However, bear in mind for laryngoplasty in tympanic membrane perforation, the main aim for this surgery is not to make the hearing better. It's actually to make the ear safer. Okay, so because when there's a perforation in the tympanic membrane, the middle ear and the inner structure is more exposed to the outer environment. Okay. For oral atresia is a congenital obstruction, congenital stenosis or obstruction of the external ear canal. Sometimes we also subject patient for canalplasty. So we create a canal or we widen the canal of the external ear canal. But this is rarely done. Okay. So most of the time, patient the conductive hearing loss is reversible. But sometimes, if the patient have like congenital malformation of the external ear canal, the pinna or the middle ear, patient may need hearing amplification. Because no amount of medical therapy can help, and surgical therapy is not suitable for everyone. Okay, so we usually will subject the patient for bone conduction hearing aids. So this is how conductive hearing loss will look on audiogram. So round red is for right ear, blue X is for left ear. Okay. When we talk, that's okay. So the round and X is correlates to your A conduction. So the other symbols, which looks like an ear, okay. So the ear thing is bone conduction. So in conductive hearing loss, the A conduction is reduced. However, the bone conduction will remain normal because the bone conduction correlates to your cochlear reserved or cochlear function. Because in conductive hearing loss, we know that the pathology is in the external middle ear. So there's nothing wrong with your cochlea supposedly. So this is how the conductive hearing loss will look like. So if in exams, we give you this type of photo audiogram, you need to first see where is the bone conduction. Is the bone conduction normal? So if the bone conduction is normal, and then next you have to see where is the A conduction. If the A conduction is like lowered down, reduced, and so this is most likely conductive hearing loss. Okay, so later I will tell you how it looks like for sensorineural. Okay, moving on to sensorineural hearing loss. So we've talked about like pathology in the external and also middle ear. So sensorineural is when there's pathology in the cochlea or beyond it up to the brain. Okay, there's lesion along, so it's a long pathway, so anything can happen along this pathway. So it can cause a different degree of sensorineural hearing loss. So when you perform a tuning fork test, the RNA should be positive. It's different from your conductive, whereby the bone conduction is better than conduction, but in sensorineural hearing loss, the RNA should be positive. The A conduction will be better than bone conduction. And when you perform Hairburst, it will be lateralized to the good ear, not the bad ear. So there's also a long list of possible causes of sensorineural hearing loss. It can be congenital, okay, it can be acquired. So what we commonly seen in adult would be the acquired type. Okay, there's noise induced due to aging presbycusis. It can be sudden sensorineural hearing loss, which is like an emergency. Okay, it could be secondary to trauma, infection, autotoxicity. So it might be because of chemotherapy or like antibiotic, which is autotoxic to the cochlea. Can cause hearing loss. Also, it might be because of tumor or vascular compromised. So this is vestibular schwannoma, acoustic neuroma. Okay, because one of the causes of sensorineural loss is vestibular schwannoma. So this is a tumor in the vestibular nerve. Okay, this is how it looks like on MRI. So it looks like an ice cream cone. The ice cream is the tumor within the cerebellopontine angle, and the cone is the internal auditory meatus. Okay. So how do we treat sensorineural hearing loss? It's the same as conductive hearing loss. You must need to identify first what is the possible causes, because there's a long list of the possible causes of pathology that can cause sensorineural hearing loss. But usually you can gather the most possible one based on history. So history taking is very, very important. Okay, and also when you perform examination. So most of the time for sudden sensorineural hearing loss, we will prescribe patient with steroids. Most of the time we can treat the patient as outpatient, so we give oral steroid. And some patient who has diabetics or like lives very far from the hospital, you might need to admit and give intravenous steroid therapy. Other causes of hearing loss is Menial's disease. So Menial's disease, you can read about Menial's disease. It's a type of hearing loss that can cause fluctuating type of hearing loss. So we can treat it medically most of the time with low sodium diet, diuretics is like furosemide, but rarely given, and also beta-histines. Like for the vestibular schwannoma that I showed earlier in the slides, the mainstay treatment is surgery. However, because it's a benign, slow-growing tumor, we can actually adopt a wait-and-see type of treatment until up to a point that it gets very big and it has compromised the hearing. Okay. Right. So, if the hearing level is severe to profound or moderate to severe, and it is irreversible, it can be reversed by medical or surgical therapy. This patient, we will offer hearing amplification, hearing rehab. So we will offer the patient for hearing aid first, and then lately we also, in the recent years, we also prescribe patient with a cochlear implant. Cochlear implant is very expensive, but however, some patient is will willingly spend like 70 to 80,000 for a cochlear implant. Okay. So this is how it looks like on the audiogram. So like for conductive hearing loss, I mentioned earlier that the first thing you need to see is where is the bone conduction. Okay, the bone conduction is like the thing like the ear thing. Okay, not the round and the X. The round and X is air conduction. So you'll see here the bone conduction has been reduced, and the air conduction is also reduced. And between the air conduction and bone conduction, there's no gap. So both of them reduce together. So this is what we call the sensorineural type of proton audiogram. Okay. We talk a bit about presbycusis. So it's a progressive hearing loss associated with age. Okay, so you will see this in patient above 65 years old, usually bilateral and almost symmetrical on proton audiogram. However, we also see early onset presbycusis. This is usually familial. So if you see like a 30-year-old or 40-year-old with presbycusis type of hearing loss, you have to ask the family members, is there anyone in the family also have early onset hearing loss? Okay. So what are the clinical features for presbycusis? Patient will present with progressive hearing loss. So they might not be able to tell you that they have hearing loss because they have lived with it and they have adapt to having this hearing loss. But they will tell you that they have difficulty in hearing in noisy environment. So when they went to Kenduri, they went to any event, to the market, they will have difficulty in hearing. And when somebody is talking to them, they won't be able to receive the sound effectively. They might also, one of the common presentation to us is also tinnitus. So there's a ringing sound in the ear, and the most common reason why patient have tinnitus is hearing loss. So you have to investigate. So speech discrimination score is a speech audiogram. It's a test of its own. So they will have a poor speech discrimination score, and so this is more like audiology type of assessment. So they also have recruitment, and for elderly who have difficulty in hearing, they can't participate in a conversation, especially like when my family is gathering, when they attend event. So they might present to you with depression. Okay. So next, I will talk briefly about noise-induced hearing loss. So you'll see here, this is the environmental sound. This is how it correlates with the how high is the decibels. You will see like the gunshot explosion is very, very explosive. Okay, so it's like 140 dB is very, very loud compared to like vacuum cleaner is like 80 dB, and that is already loud enough. Imagine a gunshot or explosion. So for noise-induced hearing loss, when we give you a proton audiogram which looks like this, there's a dip in the 4 kilohertz. So the first thing that you have to run into your mind is possible, the most possible diagnosis is noise-induced hearing loss. Okay. So the definition of noise-induced hearing loss is when the hearing loss which followed exposure to loud noise. So this is what you gather from history. So there's two types of noise-induced hearing loss. It could be acute acoustic trauma, which occurs quite acutely, like short history, or occupation-related noise-induced hearing loss. A patient who worked in factories, who were exposed to loud noise for a long period of time, almost 5 to 6 days a week. Okay, so eventually, when they have retired, when they have gotten a bit older, they'll realize they have hearing loss. So in the audiogram, we show a typical dip at 4 kilohertz. Okay. So this is how you define acute acoustic trauma and also occupation-related noise-induced hearing loss. Usually acute acoustic trauma is when you ask the patient history, they might be exposed to loud gunshot, explosion. It's like a sudden exposure to this loud noise. Okay, so when you're exposed to sudden super loud noise, what the ear will try to do, it has this protective mechanism where the ossicles will contract. The muscles which attach to the ossicles will contract to protect the inner ear. Okay, sometimes because they're trying to work so hard, everything it can cause rupture or dislocation of the disruption or dislocation of the ossicular chain. And sometimes when the ossicular chain, when the ossicles put the tibial membrane too fast, or like the energy is too much, it can cause rupture of the tibial membrane. The most common one, the more common one that we see is the occupation related noise-induced hearing loss. So you will see this in workers who works in factories, or those who handle machines, those like works at the roadside, and they use a lot of machines which is very noisy. So exposure to this for a long period of time, we can cause noise-induced hearing loss. So when we manage this type of hearing loss, first we have to prevent. Okay, we advise them to wear earplugs, ear muffs, so that like whatever sound from the environment will be not transmitted fully to the inner ear. But most of the time, they will already come to you very late in the maybe when they are already retired. So at this point, we will only offer rehabilitation, like hearing aid. Kejap sorry. So moving on, sudden sensorineural hearing loss is an ENT emergency. So with regards to ear diseases, sudden sensorineural hearing loss is an emergency. We take it very seriously. We take this very seriously. So it is defined as hearing loss of more than 30 dB in 3 contiguous frequency. So 3 contiguous frequency meaning that frequency which right next to each other. Like in proton audiogram, you will see like 500, after 500 is 1 kilohertz, and 2 kilohertz, 4 kilohertz, 8 kilohertz. So this is what we call contiguous, is next to each other. Okay, hearing loss of more than 30 dB. Most of the time, we don't know what is the patient's baseline, but we assume that a patient who was previously having normal hearing, the hearing level is at like negative 10 to 10 dB. So it goes beyond 40 dB, and the history is very suggestive, then we will call this a sudden sensorineural hearing loss. And it occurs within 3 days. But however, unfortunately, most patients will come to us very late, maybe after a week, after a month even. So it is mostly unilateral, only one ear is affected. 95% of the time it's idiopathic. So despite we investigate like we do blood investigation, we do radiological investigation, we couldn't find the cause. But there's a long list of possible causes. And but most of the time the treatment that we give is corticosteroid. Like I mentioned earlier, it can be given systemically, orally as outpatient, or as inpatient we give intravenous. And sometimes we also give corticosteroid trans-tympanic membrane, so intratympanic. We will inject into the middle ear via the tympanic membrane. So the recovery can either be complete, partial, or no recovery. So complete recovery is when the patient able to, when the patient say like I can hear like back to normal, almost back to normal. So there's like within like 10 dB of the previous hearing of the baseline, or partial when there's like more than 50% of recovery from the hearing loss, and there's also we see patient who has like no improvement. Okay, so despite given therapy, the hearing loss still remain very poor. Okay, so this is another diagram showing where is the possible pathology when you talk about conductive hearing loss and also sensory hearing loss. So next is like a mixed hearing loss. So what happens is when there's pathology in both both anatomy and area of the ear, okay, the middle and external ear, and also the cochlea or retrocochlea. So this is what we call mixed hearing loss. So when you perform an audiogram, you will see that the bone conduction is also not normal, and the A crossing is also not normal. And between this A and bone, there's A bone gap. Okay, so this is what we call mixed hearing loss. So most of the time, the conductive part of the hearing loss can be managed medically or surgically, can be reversed. However, the sensorineural part of this mixed hearing loss is permanent. So we need to eventually rehab the patient if patient wants to be rehabbed. So the treatment, like I said, we usually will manage the conductive component of the mixed hearing loss. If it's like middle ear effusion, we can treat it medically by intranasal steroid, by giving antihistamine, or to reduce the fluid in the middle ear. And if it's persistent, we can also perform laryngotomy and grommet insertion. But the sensorineural part, which correlates to the cochlear loss or cochlear hearing loss, usually it is irreversible and has to be rehabbed by means of amplification using hearing aid or cochlear implant. So when we talk about hearing rehabilitation, there's different type of hearing rehabilitation. You can use the conventional hearing aids. This is what we usually see in our population, in the elderly population. We can also, maybe you've seen this before, there's a bone conduction hearing aids. So bone conduction hearing aids is type of hearing aid which amplify the sound directly into the cochlea. So it will bypass the pinna and also the external and middle ear. So this is good for a patient who has malformed middle ear, external ear, and also pinna. So we also have middle ear implants. So middle ear implants is a type of hearing amplification which we implant into the ossicles or the round window of the middle ear. And there's also cochlear implant, whereby we insert and amplify directly the hair cells in the cochlea. So this conventional hearing aid. So we have an ear mold. So it will fit up to the patient's ear canal, also pinna, and then you can see there's different type, okay, different size of hearing aid. So the audiologist will tell the patient which type will be better for them, and then and also preference. So as like handphones, so the more powerful one, okay, the more canggih one, very nice one, will be more expensive compared to the conventional normal ones. So it is a diagram showing the different type of hearing aids, okay. and then one is like behind the ear, the normal one we see. One is some is only in the canal, some even not be able to see. It's like deeply inside the canal. Okay. So this is how bone conduction works. Okay, it requires surgery. Okay, we have to implant something on the temporal bone on the skull, and the skull will vibrate the cochlea directly, and this will transmit it to the brain. So it will bypass all the structures of the external ear and middle ear. Okay, this is how it looks like on a patient with bone conduction hearing aid. So in this, like this tiny girl, it is not. It is like a soft band. This is what we call soft band baha. So it's not. It's not. It doesn't require any surgery, but eventually she will need a surgery. Okay, this is like just to make her get used to having this bone active hearing aid on her and how it amplify the cochlea. So as she grow older, usually after the age of 5, we will surgically implant the like this, okay, the bone conduction hearing aid, because pediatrics skull is very thin, so the abutment has a different has a certain length, and usually after 5 years old, the thickness of children's skull is good enough and compatible to this titanium abutment and the implant and abutment. So this cochlear implant, just briefly, so it has different components: the sound processor, the internal implant, the electrodes. So the electrodes will be directly implanted into the cochlea. Okay, so inshallah, if someday you might be able to witness how this is being performed. So it requires very meticulous type of surgery. Okay. Yeah. So basically, cochlear implant, it will amplify the remnant of hair cells in the cochlea directly. So regardless like what's happening in the middle ear and also external ear. So this is how it looks like. It looks like kind of like a conventional hearing aid, but you will see that there's the supplementary thing on top of the scalp. Okay, this is where the processor, sound processor is. Okay. You can see the receiver and the internal implant is in the internal implant, and also the electrode is within the ear, and the sound processor and also the receiver is outside. Okay, it's externally. Okay. So a little bit about the soils of the inner ear. There's also a long list of possible causes of inner ear pathology. This it can be because of acoustic neuroma, like we mentioned earlier. It can be because of these issues of with the labyrinth organ. Okay, it can be because of drugs. It can be chemotherapy or antibiotics can cause toxicity. Noise-induced Menial disease, labyrinthitis is infection of the labyrinth. Vestibular neuritis is inflammation of the vestibular nerve. Cochlear vestibular malformation is a congenital malformation of the cochlea and also the vestibule. And also auditory neuropathy is a congenital type of nerve pathology. Okay, so this is just how it looks like. The anatomy of the inner ear, it consists of the cochlea and also the labyrinth, and how it looks like within the cochlea, the movement of the perilimb and endolimb, which eventually this movement of the fluid and the different content of endolimb and perilimb endolimb, which can cause which convert mechanical to electrical type of energy. So this is the auditory pathway, how the sound transmitted from environment up into the brain, into the auditory cortex. So it's a long pathway, so anything could happen. So patient post-stroke can also present it to you with hearing loss, because somewhere along the line there might be a pathology which has affected the auditory pathway. Okay, I think this thing you can read yourself about lingering. Okay. Is there any question about hearing loss? I think Dr. Eileen will talk to you about noise induced or maybe hearing loss in general. But what I want to focus on is you need to identify the different type of hearing loss. Okay, conductive type. You need to know when we give you a printed audiogram in your exam. You need to be able to identify, is this conductive type, sensory neural type, or is this mixed type of hearing loss. So once you have identified the type of hearing loss, you need to know the severity. Is it mild, moderate, according to the severity levels that I've mentioned before, and also right or left. Okay, so left, remember left is X, right is round, that's for a conduction. So you need to, when you give your audiogram, we want you to be able to know, is this the right or the left ear affected, the type of hearing loss, is this conductive or sensory neural, and the level, it is mild, moderate, severe, or profound. Yeah, usually that's what we want you guys to be able to identify. Sometimes we will also give you a scenario. If it's let's say the scenario is about middle ear pathology. So most likely, so sometimes we give you a audiogram. So it looks like conductive hearing loss. So we will ask you what are the possible diagnoses, okay, that can cause this type of hearing loss. So remember, conductive hearing loss, the pathology can either be the pinna, the external ear canal, or the middle ear. So these are the things that you need to, because there's a long list, so you can list any pathology which involves just these three structures. Okay, there's conductive type of hearing loss. It could be middle ear effusion, chronic dysmedia, any bony masses, or any tumor in the external ear or middle ear, okay, or any absence of pinna. It can also cause the conductive type of hearing loss. However, if the pure tone audiogram showed sensory neural type of hearing loss, so you need to know that the pathology is somewhere in the cochlea or up into the brain along the auditory pathway. So you need to list down what are the possible causes. It can be vestibular neuroma, it can be like stroke, CVA can also cause, okay. Patient might have a labyrinthitis or Meniere's disease, okay. So this is the thing that you need to identify, because this is the thing that we will ask you, okay, in general, hearing loss in pediatric, in ENT. So we talk about rehabilitation. Say like if we ask you about like how do you manage it. So if it's a conductive type hearing loss, and we give you a picture of say middle ear effusion. So first thing first, most of the time we treat everything medically. If we can't treat medically, we might subject the patient for surgical interventions like Stabilotomy and format. So these are the things you need to know. Okay. Any questions? Are you guys the same batch that I give lectures before? Okay, definition of the, what does it mean by trichotic? Oh, okay. You don't understand the trichotic. Okay, when you see a pure tone audiogram, okay, oh, you're not the same batch, yeah? Different batch, is it? Oh, I'm confused now. So you guys have not received my middle ear and external ear diseases lecture? Oh dah, okay, the same. Okay, dah. So you guys are the same batch. Saya confused lah sekarang. Okay. Okay, about tricontiguous. I'll show you again. What does it mean? Sekejap ya. Okay, when you see a photo diagram, okay, this is just like, you will see like on your y-axis is the degree of hearing loss. Okay, this is not a nice one. Okay, yang ni lah. Okay, so on your y-axis, your degree of hearing loss, okay, 10, 20, 30, 40 dB. So in your x-axis is the different frequency. Okay, so usually our machine will show you 250 to 8 kilohertz. So what they mean by three contiguous is when the hearing loss is at 250, 500, 1000. They're next to each other. That's what is mean by contiguous. Or it can be like 1, 2, 4, 500, 1, 2, macam tu. Okay, that's what it means by pre-contiguous. So because like if it's not, like maybe like 500 is lost, but 1000 is normal, 2000 is normal, then there's drop in 4. So that's not what it means by pre-contiguous or sudden hearing loss. Okay, boleh faham? Gitu. Why got hearing loss? Okay, Hairburst Test is very, very sensitive and is very, I like to perform Hairburst before Renes, but it's just my preference because it will let me know the type of hearing loss. Hairburst Test is very sensitive. It can show you difference of only 5 dB between both ears because Hairburst Test tell us the function of the cochlea. So in conductive hearing loss, there is issues in the external and middle ear, but the cochlea is good. Okay, so that's why the Hairburst will it will tell you that the cochlea is good. Okay, boleh. Okay, it will when you perform a Hairburst test, it will tell you like which cochlea is better. So in sensory neural hearing loss, it will lateralize to the good ear because that good ear, the cochlea is good. Tapi in sensory neural hearing loss, we know that the pathology is in the cochlea. So the affected ear, the cochlea is bad, so it will lateralize to. It will look for a better the cochlea which is better, which is the contralateral side. However, in conductive hearing loss, somehow it will still be to the affected side because you will feel that everything is concentrated to the cochlea. You will try to concentrate actually kan, when we talk about Hairburst test, sometimes a patient will have equal type of Hairburst in conductive hearing loss unless like the hearing loss is very, very severe, and then it will lateralize to the bad ear. Macam boleh faham ke? How to say so Hairburst test is a test of cochlear function. So in sensory neural hearing loss, it will look for the better cochlea. So it will lateralize to the good ear. But however, in conductive type hearing loss, usually it is you will see the patient will have equal type of Hairburst test because both cochlea are normal. But somehow because the external and the middle ear there's a pathology, that cochlea will try to work harder. So that's why even in your Renes test, the bone conduction will be better than the air conduction. So the cochlea is like working extra hard. So that's why you will hear that the Renes test is better in the bone conduction, and even you perform Hairburst test, it will lateralize to the bad ear. But most of the time, the Renes will be positive on the bad ear in conductive hearing loss, but the Hairburst will be like almost equal. Yeah. Okay. Acute otitis trauma. So usually for acute otitis trauma, we can't do much. Management. Okay, when you talk about management, it also include investigation, okay, and assessment. So remember, okay, if we ask you about management question, you have to talk about investigation or assessment. So first we assess whether there's any typic membrane perforation, And then after treatment confession, we also will investigate further. We perform proton audiogram. We perform proton audiogram to see the degree of hearing loss and whether it's like only mild, moderate, or severe to profound. Now, subsequently, if it's like say moderate, severe to profound, we will subject the patient for CT scan because we want to see what's going on in the middle ear, the ossicles, what's happening. Sometimes we might do ossicloplasty. Ossicloplasty is we try to reconstruct the ossicles which has been dislocated together with tympanoplasty. So whereby we reconstruct the tibial membrane which has been perforated, and this will help to amplify it to make the hearing better. However, not many centers do this, ossicloplasty and also tympanoplasty. So most of the time we will subject patient for hearing rehab, just using hearing aid, okay, to amplify the hearing. However, it is a type of severe to profound type, sensorineural. We might not be able to, so ossicloplasty and also tympanoplasty might not help to restore the hearing because the hearing level is no longer conductive type, but it's already sensorineural. Okay, so if the basilar membrane has been ruptured and on proton audiogram, we see that it's only severe to profound. So most of the time we will not offer any type of reconstruction, but we will straight away inform the patient you will need a hearing rehab. Usually there's no medical therapy for this lah, like acoustic neuroma. But most of the time, patient will come to you with only mild to moderate. So if it's only mild to moderate, sometimes we check out, oh, it's okay, I don't need anything. Unless they come to you with very bad severe to profound, they might need some help with rehabilitation or reconstruction. Both okay, bone conduction, conductive hearing loss, there's no bone gap. Bone conduction, there's no okay. Oh, how to differentiate between bone conduction? Okay, mixed hearing loss, the bone is abnormal. Okay. See, in conductive hearing loss, there's no bone gap. Tapi the bone punya conduction is still within normal range. It's still within negative 10 to 10. It's normal. But the A conduction, the round and the X, dah reduced. Okay, this one on the right side, left side is normal. So this is conductive hearing loss. But in moderate, in mixed, in mixed, you'll see here, the bone pun tak normal, is coming down, and the A pun memang dah abnormal. So that's why I said like you need to see first the bone conduction. First you see the bone conduction. Oh, it's abnormal. So is this sensorineural? And then you see the A conduction. Oh, it's also abnormal. But and then the next thing you need to see, is there any air bone gap? If there's no air bone gap, this is sensorineural. If there's air bone gap, this is mixed hearing loss. Okay, so conductive hearing loss, bone conduction is normal, air conduction is abnormal, and then there's air bone gap, that's conductive. In sensorineural, the bone is abnormal, the air is abnormal, and there's no air bone gap. Okay, both jatuh together. But in mixed, bone is abnormal, the A is abnormal, but there's a bone gap in between. So most of the time, this patient have sensorineural hearing loss. However, there's also another pathology that can cause the conductive element of the hearing loss. That's why we try to treat the conductive element in the mixed hearing loss. So sometimes with this therapy, the hearing loss might improve a little bit. unless like it's already severely profound, we have to rehab the hearing.
Faham? Terima kasih doktor.
Okay. You can Google this thing lah. You tengok different type pyotonogram. Nanti when you come to the clinic, you will see different types of pyotonogram because you need to read this. We will ask you in question. It might be in your essay, it can be in your viva. Okay, so because sometimes in your previous group tu, previous even final pro pun they can't differentiate the different type of pyotonogram. It is conductive ke, sensorineural ke. Okay. There's only a few things that you need to know lah in ENT, and we like to ask you about autology somehow. Okay. Okay, 5 minutes break. Yeah, I need to see a patient in clinic kejap. Okay, so the next topic that I want to give is about tinnitus. Okay, tinnitus is also a very important topic. Maybe not so much to the undergrad, but important for the postgrad also, the audiology punya student. Okay, but it's good to have a little bit basic understanding of tinnitus because you will see that a lot of patients present to you even in primary setting. Okay, in about tinnitus, okay, this ringing sound in the ear. So I have to go a bit quickly because I have to attend another class at 3:30. Okay, inshallah. But it's okay. I will email you this slide because I don't think I've given these slides to your seniors before. Okay, Bismillahirrahmanirrahim. So tinnitus, boleh tengok can you guys see my slides?
Yes, doctor.
Okay, so this is the outline of my presentation. So introduction, definition, the pathophysio, why the patient have tinnitus, the possible diagnosis, how do we investigate, how do we manage patient with tinnitus. So as introduction, how we define tinnitus. How we define. So tinnitus is a very common presenting symptoms. You will see quite a number of adults presenting with tinnitus, and it's higher. The prevalence is higher in those with hearing impairment. Okay, those with hearing lost. For now, there's no medication that we can prescribe to the patient to reduce or treat tinnitus as for now. Okay, there's no drugs. So when we talk about management of tinnitus, we're talking about how to improve the patient's quality of life and how to reduce the psychological stress. Because if you have a persistent ringing in your ear, it is not, it is, you will commonly see patient of tinnitus who have depression. Okay. So how do we define tinnitus? So tinnitus is a cessation of sound in the ear in the absence of any acoustic or external stimuli. So there's nothing, there's no environmental sound which stimulate the brain for the brain to perceive sound. However, patients still say that, oh, I can hear this thing ringing. Okay, so that's what it means. So the patient feels that there's sound in the ear, but but the sound that they're hearing is not from the external environment. So there's no stimuli. So traditionally, we classify into peripheral or central. Central is like in the brain or it's like in the ear. Okay, and also it is subjective or objective. Subjective is this is what we commonly see in patient with tinnitus. Only the patient can hear the sound. The physician, the audiologist, nobody can hear the sound. But in small percentage, both the patient and the clinician can hear the sound. So this is a new current classification of tinnitus. Okay, they classify it to somato sound or phantom auditory perception. So we talk about somato sound. There is a possible causes around the middle ear or the inner ear that contribute to the formation of this sound. So it can be a vascular harm, a venous harm, or is it a transmission from the carotid artery? Because it's when you Google the image of our middle ear and our carotid and jugular vein, it is like very closely related. Okay, so it might actually be transmitted sound from venous harm or carotid artery. So it can also be because of muscular contraction or any joint problem. Okay. So another classification is phantom. So there's no sound generator that can be identified. So it can be sub-classified into dominant peripheral or dominant central. So peripheral is like this patient can hear sound but it's meaningless. But we also have to rule out is this auditory hallucination. So auditory hallucination you can see in patient with psychiatric problem like so they have to differentiate between these two. So sometimes patient with tinnitus who has depression and like a bit of aggression, we might need our psychiatric clinic to have a look. So this is like another table to show the different types of tinnitus. Okay, is it primary or secondary? Is there any causes of it? There's no cause of it. Is it persistent or is it just like recently occurring? So if it's less than 6 months, it's recent onset. If it's more than 6 months, it's persistent tinnitus. Is how we define it. And we also ask patient, does this sound in your ear bothers you? Are you able to sleep? So sleep is very important. If the patient said that, the sound is too bothersome, that I can't even sleep, so patient might need some sort of medication to help them sleep. Okay. So there are several theory as to why this tinnitus can happen. So there's different there are theories of the pathophysiology. The unknown cause is still not known. Okay, the exact cause is still not known, but there are suggested theories. Okay, they said that there might be any issues in the cochlea, so any damages in the cochlea can cause a tinnitus formation, or is there any damages along the auditory nerve and the auditory pathway can also cause this overexcitation of the excitatory impulse that can cause tinnitus formation. And also, is there any problem in the brain? Okay, so because when there's any pathology along this in the cochlea or any along the auditory pathway, can cause the can cause any what we call that discordant between the firing and also disinhibition, over excitation and also inhibition. So even though there's no sound, but the brain perceives there's sound. So this is what we call as over excitation of the action potential impulses. So this is another diagram showing the possible physio. This how the patient might present to you. Like status, it may be ringing sound, buzzing sound, clicking, hissing, humming. Okay, this is how they might tell you from the history. So you need to figure out what is the possible cause, and the most common reason, the most common uh, underlying cause of tinnitus is hearing loss. So you need to identify, does the patient have hearing loss? So subject the patient for with an audiogram. So we need to identify next whether the hearing loss is due to cochlear pathology or like beyond that up to the brain. Okay, so this is how it looks like. This is another diagram showing like why patient have tinnitus. So there's alteration in the neuronal activities in the cochlea and also along the auditory pathway. So the brain perceives the sound when there's no external stimuli, okay, because there's excessive firing of the action potential. So these are the possible causes of why the patient have hearing loss, and eventually patient will cause persistent tinnitus. So the differential diagnosis is why patient have tinnitus. First, you need to rule out what is the reason why the patient have hearing loss. It can be there's some disease in the outer ear, middle ear, or inner ear, like mentioned earlier. It can also because of sensory hearing loss due to drugs, chemotherapy, or any antibiotics. It can cause toxic to the cochlea. It can also be because of systemic diseases. So how we do investigate tinnitus? First, we need to identify whether it is only one ear or is this like both ear affected, and then whether the sound is centered in the head, because we need to identify, is this like peripheral type of sound, or is this like auditory hallucination? And subsequently, we need to identify what is the possible causes. Is it like vascular harm? Is it venous harm? Is it like transmission from the carotid artery? Is it like because of muscle contraction of the palate, of the incision tube, of the soft palate? Is it because of the joint of the TMJ joint which is adjacent to the external ear canal, causing the sound? And we take history about tinnitus. We need to also ask them about the quality, okay, the type of the sound, the loudness. Is it like low frequency or high frequency type of tinnitus, and then does it varies over time over the day. So most of the time patient will say like it is more prominent when I'm in a quiet environment, so I don't really perceive the sound much. It really doesn't bother me much when I'm when I'm around other people, when I'm outside, in the maybe when they went to market where everything is so noisy in the environment. So these are when you take history from patient, and you can figure out like whether you can figure out from the history itself like what the patient, what is the possible causes of this hearing loss, and the significance behind having good history. Okay. So first we have to examine the ear. So when we talk about management, first we need to assess the patient, examine the ear using otoscopy. Is there any obstruction of the ear canal? Any signs of middle ear diseases? For venous harm, we rarely do this, but we can actually perform this jugular compression test. So basically, we compress the jugular vein, and if the sound is transmitted from a venous harm, as we occlude the jugular vein, the sound will disappear. That's the idea. Okay. Hopefully, when you're in clinic later, we will we will show you how we perform nasoendoscopy and what does it mean by petalous EP, eustachian tube. Okay. And we also examine the oral cavity, looking for any soft palate contraction, palatal myoclonus. Okay. Sometimes when patient have muscular diseases that can cause contraction of the soft palate, muscles of the soft palate, it can be transmitted into the ear as a tinnitus. And also, is there any TMJ, temporomandibular joint diseases like Costin syndrome especially? So we talk about physical activity, physical examination. The different types of findings will correlate to the significance. What are the possible underlying causes of the tinnitus? So it's very important to have a thorough assessment as examination of the patient. When we investigate further, after we have done history taking also and bedside assessment, we will then subject the patient for audiological investigation, because we know the most common reason why patient have tinnitus is because they have hearing loss. So to ascertain whether the patient really have a hearing loss is we subject the patient for pure audiogram and refer to audiologist. So we will see whether the patient does have a hearing loss or not. So pitch making, harmonious matching is done by audiologists. So basically, like they have a machine that can depict the sound of tinnitus, and they can match this. Okay, it's like maybe when you have your session with your audiologist, you can ask them how do they do this. Okay. And we also perform blood investigation, lab investigation to rule out any possible causes of tinnitus, because anemia is also a known cause of tinnitus. So we need to do maybe one of the investigation you can do is food blood count. And next, we sometimes certain smoke sensitive patient, we also subject them for radiological assessment. It's either CT scan of the temporal bone, middle ear, or the CT MRI of the internal auditory meatus and brain. So this is usually in the cases of pulsatile tinnitus. Pulsatile tinnitus is when the tinnitus, the patient will tell you the tinnitus is the same as their heartbeat. Okay, so it correlates with heartbeat, the tinnitus. So this is what we call as pulsatile tinnitus. So we need to rule out, is there any vascular tumor in the middle ear or in the somewhere in the internal auditory meatus. Okay, so usually we do CT scan first, and then we do MRI, because CT scan is more readily available. You can do very quickly. MRI usually have a long list of have a long queue. So most of the time we will subject the patient for CT scan first, and then subsequently, if needed, we will arrange for MRI. Okay, we'll see whether you can see this video or not. Can you guys see the video?
Yes.
Okay, it's very scary kan. So this is from auto-endoscopy, but sometimes you will also should be able to see this on otoscopy. So when we perform otoscopic examination, we saw that there's something pulsatile medial to the intact tympanic membrane. So the first thing you need to see is, you need to think of is there might be a vascular tumor medial to the tympanic membrane. So don't try to poke the tympanic membrane. So you need to, because like if you try to manipulate the tympanic membrane or the middle ear, it will bleed. It will bleed to glory lah basically. So you have to subject the patient for CT scan and subsequently maybe MRI or MRA angiogram. So this patient is a glomus tumor. It's a glomus, most likely is glomus tympanicum. Okay, it looks very scary. So if you see this in outpatient setting, okay, or maybe later in your career, so don't do anything, don't be a hero, refer to ENT. Okay. Right. So the picture lower down is I mentioned earlier, is acoustic neuroma. So when you talk about cerebellopontine angle mass, there's a long list of differential diagnosis. They can have a mass in the cerebellopontine area. Okay, sorry. Okay. So this is just another assessment when you see a patient tinnitus. How does we just want to quantify how tinnitus has affected their daily lifestyle? Okay, it's like Sanika inventory to see does the patient needs further assessment by our psychiatric clinic or not, or does the patient have need to be put on any antidepressant medication or anxiolytics. Okay, so medical therapy. There's no specific drugs that has been approved by FDA to treat tinnitus, so there's no one drugs. If the patient might tell you, oh, I read this on the internet, they can treat tinnitus. So far, as FDA is a concern, okay, there's no specific drugs and reduce tinnitus. But if the patient presented to you with depression or inability to sleep and has become more is very deeply affected by tinnitus, he might be able to give them antidepressant, antidepressant, or anxiolytics, okay, to help them to have a better quality of life. So the other interesting thing that of recent years, okay, that we can prescribe patient is sound therapy. Sound therapy. So basically, when you talk about like Muslim, like Islam point of view, usually we will tell the patient, oh, if you are unable to sleep, what you can do is you just open up the radio, all this like surah is like open it up, because like what we feel, what because the patient will tell you, they will hear this tinnitus even louder, it will affect them more when they're in quiet environment. So we want them to sleep or sleep with a background sound. So this is the idea of sound therapy. So they might put on songs or like Quranic verses. So it's up to them. Okay, most of the time it will help them. But some people, even in the Western countries, they even create an apps for this tinnitus patient to sleep better. So if the audiologist can match the frequency of tinnitus, we can actually mask the tinnitus by giving the same frequency, because it will cancel off. So that's what we call tinnitus masking therapy. This is very technical, but this is what's happening right now. Okay, the technology behind to treat patient tinnitus. So because tinnitus is most commonly due to hearing loss, so we will inform the patient, maybe hearing amplification by means of hearing aid might be able to help them with their tinnitus. Because the idea is, if you hear the environmental sound better, you will direct your brain towards the environmental sound and not to the tinnitus sound, which is generated in your inner ear. So most of the patients will say that they will benefit from this hearing amplification, hearing aid. So hearing aid plus sound therapy, usually in most patients it will help to manage their tinnitus. So another thing is the new way of managing tinnitus of recent years has been implemented is cognitive behavioral therapy, CBT. So I'm not sure if you have done your psychiatric orientation, but usually CBT is a type of treatment you give for those with severe depression or anxiety. Okay, is a type of talk therapy. You talk to the patient. So the goal of CBT is to change the patterns of thinking or behavior and change the way we feel. So when you have something ringing in your ear, you will feel depressed. You feel angry. Okay, you feel like nothing is going right in your life. So you want to change this. You want to change the thinking and behavior. This is the role of CBT. You will require a lot of session, but we want them to change their perception to this sound. Most of the time, we will tell them you need to find a hobby. You need to focus your mind to something good. If you feel good, the tinnitus won't bother you much, and eventually it will not affect your emotion much. Okay, that's the idea of it. Okay, so you were able to read this. Okay, one of it is like, say, I have tinnitus. Life is rotten, so that's it. So my life, that's the end of my life. Okay, I will never get better. But you want to change this type of mentality, this behavior and treatment into this type of thinking into like, I will get better. I might not get better, but it's okay. Right? My life is not over. Okay, this is a small part of my life, but there's more to life. I'm going to enjoy my life. So this is the type of this is the idea behind CBT, cognitive behavioral therapy. So not many patients will benefit from CBT because not all patients are motivated. So of course you have to choose which type of patient you can subject patient for CBT. Okay, those are very motivated type of patient. So I've not seen this being done. So when you talk about tinnitus, the people say that you can do this transcranial magnetic stimulation. But I don't know the science behind it because I'm not really familiar with it. But it might be a type of treatment you can give the patient. But we don't have it here in UAE. We don't have it. This is picture in USM. So it's when you talk about management of tinnitus, the patient have to help themselves. So most of it is centered with self-help type of therapy because they need to break the vicious cycle. They need to first identify that they do have this problem, and they have to find ways to accept this and deviate their attention away from this and still enjoy life. Okay, and not become deeply affected and depressed because of this. So most of the time in our clinic, we will tell the patient like, find a hobby, what do you like to do, focus on those things. Okay, um, and then eventually you will, when their mood is better, they have things to focus on, they have something to look forward to. Tinnitus will just be like a small part of their lives that they won't affect them too much. So relaxation is a type of therapy too. So we will tell the patient that we don't know whether this is does it help or not, but we will recommend to the patient like maybe you can try acupuncture, hypnotherapy, because when you relaxed, your mind will be more relaxed and your emotions will be so much better. Okay. So as a conclusion, tinnitus is not a disease by disease by itself. So it's a sign, it's a symptoms that a patient present to you, but you need to identify what is the underlying causes. So most of the time it's hearing loss. So you need to subject the patient for hearing assessment. So if it's hearing loss, you will refer to the audiologist for hearing amplification. So most of the time with hearing amplification, hearing aid, and also sound therapy, patient will be able to handle tinnitus well. And of course, we talk about self-care therapy, which is also important. Tell the patient that they need to move on with life, find something that they're happy about, and focus on that, and not focus on the things, on the tinnitus which can make them very depressed and sad. It requires a good communication between the patient, the ENT physician, and the audiologist. We need to listen to them. Okay, sometimes they just want us to listen to them. They just want to be heard, and little empathy goes a long way. Don't disregard immediately. Say, oh, there's ringing sound in the ear. Not all ringing sound in the ear is auditory hallucination. For all you know, there might be a real pathology. Okay, it might be like some vascular tumor in the middle ear, like our patient here, they have the glomus tympanicum. So we need to investigate and investigate the patient. Unless there's no based on audiological and also radiological investigation, there's no pathology, that it might be idiopathic, and we just need to tell them, let's try to live with this, but don't make it ruin your life. Just focus on the good things in life. Okay. Right. Okay, I'm a bit late. I will email this slide to Afiq. He will put up in your Google Drive. I also will give slides on presbycusis, also called acoustic neuroma, because I've given those topics to our audiology students. So I've prepared them. You can read it in detail, okay, about this. If you have any question, you can email it to me because I'm a bit in a rush. Inshallah, if you have any question, just email to me. I will answer it in later. Okay, inshallah. So thank you for your time. I might be able to take any question now. Tak apa, you can text or email me lah, boleh, inshallah. Okay.
Okay, thank you, Doctor.
Thank you everyone. Thank you.
Thank you, Doctor. Thank you.